In the ER, especially the mid-level providers in the audience tonight, we generally see the more common injured patient, the walking wounded, if you will. We're often in urgent care settings or minor emergency departments. So we are the first line to evaluate people who fall down, hurt their finger, hurt their back, sprain their ankle, and so forth. So we thought we wouldn't talk about the things we commonly see, because we're going to see enough of those, and we're all going to be excellent at recognizing, treating, referring broken wrists, broken fingers, etc. What about the things that we don't see so commonly? And I come across with just 4 things to keep our timing for today's lecture. 4 out of quite obviously very many things. So, is this working? It's working, I think. There we go. So, what are we going to talk about today? Obviously, this is only 4 of many things that could go wrong in the human body and some of the more uncommon things, but one is a distal radial ulnar joint dislocation. How many of you have ever seen one of those? Show of hands. Nobody? So, I bet you that you have, especially looking around the room, seeing people that have practiced here as long as I have. I guarantee you, you have seen it, but like me, you missed it. Secondly, perilunate and lunate injuries. It's a little more common, but still on the uncommon realm of the injuries of the hand. How many, show of hands, how many have seen one of those injuries? At least one, very good. And my favorite, Lisfranc injury, this is the one where it takes one to miss one. You have to miss it once, and you'll never, ever miss it again, and I am guilty of that. So I've seen a number of these now in my career, and I'll never forget it and never miss one again, but they can be easily missed. And lastly, the one you're all probably scratching your head like, what is this? I can't even say it, let alone know what it is. And the pelvic apophyseal avulsion fracture. This is an injury commonly in kids, but thankfully not a real common injury. So again, many, many other injuries to discuss that are uncommon, but these 4 kind of hit the top 4 that we may encounter. All right, Dr. White earlier this morning, if you remember to breakfast, talked about the biggest payout, lawsuits are neurological. And he's right about that. They are the biggest payout, greater than $3 million. However, more of us get sued over missed orthopedic injuries. And I don't know about you, but I don't like even being sued. Even if they don't collect any money, I still don't like the fact that I'm going to be sued over something that I'm going to see so frequently in the emergency room that I have to worry about litigation every day. But it is true. Of all the things that we see in the ER, orthopedic injuries are the leading cause of litigation both here in the US and in Canada. The numbers, I don't know the exact numbers. And there's good reason for this. We see a lot of them. So anytime when you increase the denominator, you're going to have more bad outcomes. You're going to have more missed cases. You see less of them, you're going to have less bad outcomes. So it's a simple math issue, right? And clearly we see more orthopedics things than we see MIs, right? For every MI you see, you'll see 20, 30, 40 orthopedic injuries in the course of a week's time. But I think the biggest reason is they aren't really easily seen on X-ray, and we aren't looking for them. I know in the emergency departments that I work in, downtown Youngstown, Boardman, sometimes at Austintown, by 11 o'clock, 12 o'clock, the ER is imploding, waiting room is full, there's people in the hallway, and it's so easy for us, whether you're a new grad, seasoned, provider, whatever, it's so easy to get task-driven. You put your head down, no distractions, somebody registers with ankle pain, your main objective is find the break. If there's no break, there's no problem. Send them out, give them a splint, throw a half aspirin at them, tell them to see the doctor. And that's where we get in trouble. We get too task-driven, we get too focused on looking for broken bones. And oftentimes the problem isn't a broken bone. In fact, it's rarely the broken bone. So, a little bit of trivia. What do you think the average interpreting rate is among radiologists, the experts now, from 1949 up until 2002? If you guessed high, you guessed right. 30%. I even read recently where some reports have it as high as 40%, but I think 30 is probably the more closer number. So of those 30%, how many of them are orthopedic? 3/4. So a third of the x-rays are missed, and 75% of those are all orthopedics. That's a pretty big number. I don't know how many x-rays we do at our hospital, but how many patients we see a year. And if everyone gets an x-ray, that's 400,000 x-rays a year, just in one location. Naturally, the more complex the area, the higher the rate of injury and also the higher rate of missing things. We have more articular joints, connections in the hands, feet, and pelvis than we do virtually anywhere else, which makes these injuries a lot harder to see. They aren't as easy as looking at two slender bones in our lower leg or in our forearm, etc. So that's why these have become difficult to recognize and very, very easy to miss. Who here drinks Snapple? A couple of you know that I drink Snapple, and I've come across a couple of these that's pretty funny. This actually is not false. This is true. Has anyone ever run out of gas in Youngstown? Apparently, somebody has, or enough people have, that someone made this rule. I always thought running out of gas was penalty enough. I can't imagine what the penalty would be by law. So I don't even want to get gas in some places in Youngstown, let alone run out of gas some places in Youngstown. Anyway, so first up, distal radial ulnar joint subluxation or dislocation. It involves, as the name would imply, the lower end. So right near the carpals of the radius and ulna. Very rarely does it ever involve any injury up near the elbow. So if we were to sort of take a picture right through the back of someone's hand, what is this joint? It's not really a joint per se. It's more closely called a notch. You can see a little recession. And the ulnar styloid sort of just rests right in there, not completely in it like a hinge on a door, but nestled in it gently. So there is a natural space. But when that space is disrupted, the ulna is then shifted laterally, and the space then becomes larger. So when we suspect one of these things, these are the questions that we ask. Why would I suspect it? What are the physical exam findings? What's the spectrum of injuries? What are the x-ray findings? And how are they reduced? So the reduction part is a little video. I actually have to turn this speaker on to make that happen. I'll do that before I forget. It's better seen than described. Let's go question by question. Number one, when do you suspect a distal radial ulnar joint injury? Well, anytime someone falls, really. If anyone falls and puts their hand out to break their fall, that is a setup for this kind of injury. And it's a natural reflex. If I were to push any one of you over, the first thing you would do after trying to punch me would be to put your arm out, break your fall. That's when this happens. Most commonly, they come into the emergency room, this child comes to the emergency room, you're going to see a broken wrist. If they're young, maybe a buccal fracture. If they're old, a nasty distal radial fracture, with or without an ulnar fracture. But it's important to remember that they don't always break their arms, but they do injure the joint. Question two, what are the physical exam findings? Well, pretty subtle actually. They're more palpable than they are visual. These patients will come in with what you would expect after a fall. There may be a lot of swelling or there may be no swelling. But one of the key points is point tenderness right over the distal ulna. It's called the ulnar fovea sign. So I like this particular physical exam better than the piano key one, as it implies, to repeatedly tap or press that area with your thumb to tell yourself or get the feeling that there is something mobile, something moving in there. The patients hate that. They don't like you touching it once, let alone pushing on it repeatedly. So I don't recommend doing that. As Dr. Rose would say, you're going to get a very bad Prescani if you keep doing that to your patients. But basically, you're going to feel crepitus. So the point is, you push on the ulnar surface, the volar surface of the wrist, and if they are tender right where that thumb is, it really hurts, you have to suspect an injury to that area. Question three, what are they? What are the spectrum? Well, like anything, simple sprains to complete dislocations, all right? So they are, as we mentioned, commonly associated with a Fuchs injury, falling on an outstretched hand. And you don't always have to have a fracture. And that's where we all screw up. We don't see a break, we assume it's a sprain, throw them in a splint or not, send them home. Keep in mind that it can also occur with other carpal injuries, and we're going to talk about one of those carpal injuries coming up next, the lunate and perilunate injuries. So if you suspect it, always examine the radial head. Fortunately, for those of you who are in training and those who've done it a while, we're already ingrained in our brain to feel up above and below injuries. And if you don't, you should, because you will pick up things that are important. So this isn't really such a big deal. We kind of do that now already with any injury. So what are the findings? Well, as I mentioned before, there is a little recess, there's a little notch on the distal radius. And on a normal person, these two x-rays are abnormal. On a normal person, this space would be much narrower, not overlapping, but much narrow. So on the AP, you're looking for greater than 2 millimeters of separation. Here, I don't know how wide that is, but it's definitely wider than 2 millimeters. But as they say in orthopedics, there's always the money x-ray. If you have a question about any injury, the first thing an orthopedic surgeon will ask you is, what's the lateral x-ray look like? It's kind of like all they want to see is the lateral x-ray, and then they work backwards from there. So if you look on the lateral x-ray, you will see that the ulna is more prominent. Distal radius is right there, right where it should be, okay? But now there's a displacement, and almost all of these are dorsal. So you'll see, if you're lucky enough, a bit of a hump or a deformity on the top side, the dorsal side of the forearm, and a palpable ulnar styloid or distal ulna on the volar surface. So how do these get reduced? What do you do? Well, once they're reduced, you can see the splint. That's the recommended splint. You want these people to be reduced at the elbow so they can't extend the arm, and more importantly, they can't rotate the arm. So by doing this, you stop the patient from rotation, okay? That's the key. So it's not to be cruel, it's not to be mean or anything, it's for their own safety. And it keeps the bones where they belong. But there is a practice here that you can do, and I'm going to show you a video, if this will play. I hope it will. On the next slide, it's about a minute long, describing you how you would reduce these. So if I can get this to play with any luck.
Distal radial ulnar joint.
Okay, so we're going to put the forearm in position where it's going to be about 10 degrees of supination. That's the open pag position. The ulnar side is going to be the fixating point. So I'm grabbing right at the ulnar styloid process, and I grab with a thenar eminence on the dorsal side, and my fingers wrap around onto the ulnar side ventrally. My mobilization hand is going to be the thenar eminence over the radial head, over the distal radius, and my hands wrap around ventrally. From this position, you can see what it looks like ventrally. Place the patient down, stabilize with the ulnar side, and I'm going to do a ventral glide of radius on a fixated ulna. Ventral glide to promote pronation. Okay? With forearm supination, I'm going to move the patient into supination, and I'm going to again try to find that 10-degree open position. If this is full pronation, full supination, I want to be at neutral, about 10 degrees, and this will become my fixating side. This hand's onto the ulna, and this hand and thenar eminence is onto the radius. And from this position, I'm going to fixate the ulna, and I'm going to do a posterior glide or dorsal glide of radius on distal ulna to promote supination.
Simple, right? In theory. All right, so once we've done that, assuming you've done all those things, they're in a splint, you've talked to the orthopedic surgeon, and they want to see them in follow-up. Who gets operated on, who doesn't? Well, it's not really the place for the emergency department provider, whether you're mid-level provider or doctor or attending to determine who needs operated on. This is often a judgment call between the patient and the orthopedic surgeon, and they have a whole list of criteria that qualifies somebody for medical conservative management versus operative management. But in any injury, whether it's a broken bone or otherwise, anything that is highly unstable clearly needs to be fixated. And again, our job in the emergency room, urgent care, office setting, wherever, is to recognize it, reduce it if you can, splint it, call the orthopedist, let them know it's coming, and then they will determine the treatment plan from there. All right. Next time someone tells you that you're nuts, you can say with certainty, well, I'm actually half bananas. Moving on to the foot. Jacques Lisfranc, the famous surgeon in Napoleon's army, got famous because he did an amputation on a soldier who got his foot caught in a stirrup. As you can imagine, your foot's in a stirrup, you fall off the horse, your foot stays, the ankle twists, and you get a nasty injury. Because of this injury, the person had necrosis, had to have gangrene set in, had to have an amputation. And then from that point on, that line of that joint in the foot has been called the Lisfranc joint, which we'll talk about in a minute. So, Lisfranc, these are easy to miss. And again, I am guilty, so I admit I missed my first one and I'll never miss another one. What is it? What's the usual mechanisms? What are the physical findings? What are the x-ray findings? What do you do if the x-rays are normal, but you still clinically suspect Lisfranc injury, as we all should? And lastly, what's the best treatment in the ED? First one, what is it? Well, as I mentioned before, it's an injury of the ligament that predominantly affects the second metatarsal, the head of the second metatarsal, and the first or medial cuneiform. There's a ligament attachment right there. It's quite strong, but it's also susceptible to injury. They're easy to miss because the x-rays and physical findings are often pretty subtle. Again, we get so fixated looking for a fracture. If we get a foot x-ray and it looks normal and we can't see any broken bones, we assume it's a sprain and we send them on their way, when in fact they may have one of the worst foot injuries you can actually undergo. How often do we miss it? Quite a bit. 20 to 30% are missed. So don't feel bad. You probably will miss one, and it will take one for you never to miss one again. So, in modern days, motor vehicle collisions are the most common. If we were still riding horses to get around, then horses would still be the number one reason because of the stirrups. So, in the advent of the automobile, motor vehicles accidents occur for them, mainly because of the braking mechanism. You're about to get into a wreck, you slam on the brake, you get into a collision, the force goes through the car, up the pedal, into your foot, causing disruption. So that is by far the most common injury. The next one would be fall from a height, and this is prominently in children, as I'll show you in the next slide. The sports, work-related, and crush injuries round out the last 25%, but most of your injuries are going to be from a fall and from car accidents. So if someone comes in involved in a car accident, complaining of foot pain, be very, very suspicious. So the usual mechanism, again, if you can imagine, you're in a horse, you're riding a horse, your foot's in a stirrup, you fall off the horse, your foot stays in, but your ankle twists. The foot has nowhere to go because the stirrup won't allow it to go anywhere. That puts stress on that joint, twists the foot, and you could either A, break something, or B, break something and have an injury to the Lisfranc joint. In sports, it's pretty common. You can imagine twisting your foot, stepping in a hole, stepping off of a curb, you don't judge it correctly, and boom, you twist your foot outward. Those are the common ways, naturally, motor vehicle collisions are number one. Children, on the other hand, don't know why this is, but it is the way it is. Children get this injury from just this mechanism, an axial load coming down on their feet, whether it's forward or toes bent, the direction of force goes downward, and unfortunately, the easiest mark, the weakest area, is that second metatarsal, and it will displace. What are the physical exam findings? Well, in a perfect world, you'll get this. This patient was kind enough to come to the emergency room about a day later and had developed big-time swelling and had a nice area of ecchymosis, but that isn't always the case. They come in usually immediately from the injury, car accident or fall. There really isn't a lot of swelling. There really is no bruising. So you have to rely on a little bit of gestalt, maybe a little bit of luck, but a high index of suspicion. This particular patient kind of made it easy. All right, the hallmark findings, swelling dorsally and bruising over the plantar surface. If you can draw a line from that second metatarsal, that's where the injury is, that's predominantly where the center of that bruising occurs. As in any injury, going back to examining a patient above and below, we're pretty good at this aspect also. We're pretty good at checking pulses, okay? This is one where you really have to be careful because of that injury, because of where it's located, at that second metatarsal joint. That's where the dorsalis medius artery runs through. So if you disrupt that ligament, if you have displacement, significant displacement, you can in fact injure that artery. So if you can't feel something on examination, get a Doppler. If you can't Doppler a pulse, then you've got a real big problem, and that's an orthopedic emergency. Okay, so what are the common x-rays? So we talked about the mechanisms, we talked about who gets it, kids versus adults, but what do we see on x-ray? So person comes to the emergency room, they were involved in a motor vehicle crash, and here's their films. They have pain to their foot. You look at their x-rays and you're in a hurry, you want to go home, it's your last patient of the day, you're following the bones going not broken, not broken, not broken, not broken, not broken, bye-bye. They can go home. If you look at it a little bit closer though, when you're not in such a big hurry, you'll notice that although the AP looks fairly normal, the oblique and the lateral look very abnormal. And once you see these and get this into your mindset, you'll recognize this very, very easily like you would any other injury. Look for a dorsally displaced second cuneiform, or second metatarsal. Here on the oblique x-ray, you want to look for widening. On the next film I'm going to show you, these lines should line up with this bone there, and you can see they're shifted off towards the left. These are the lines I'm referring to. So misalignment, common x-ray findings. Misalignment, these are normal, okay? This patient on the figure A has a normal alignment of their second metatarsal. If you drew a line in a curvilinear fashion, you would see that the base of that metatarsal lines up with the medial edge of the middle cuneiform, okay? Now, because of the overlapping, the shadowing of the other two metatarsals, it's hard to see where they start, where they end. So you really can't say for certain where the third and fourth metatarsals line up along those cuneiforms. So that's where the oblique x-ray comes into play. So on the oblique x-ray, takes that out of the equation, clarifies things. You can see these bones a little bit clearer, and you can also see the edges of the middle cuneiform, and you can draw a line through each one of those. So the third and the fourth should line up on either side of the middle cuneiform. If they don't, suspect an injury. All right, more common injuries, or more common x-rays. Widening, you want to look for widening of the joint. This is pretty subtle. That's a very subtle x-ray. It looks pretty normal, okay? But there's actually a sprain there. I probably wouldn't expect anyone to recognize that. That would be up to an orthopedist or an MRI to best diagnose. But this is really a pretty normal looking joint. On the other hand, you have a displaced joint. You can see where the second metatarsal is pushed laterally. The first appears to be where it belongs, and the second one is pushed laterally. There's a big space right there. Anything greater than 2 millimeters is considered a surgical intervention. Blowing that x-ray up a little bit further, you can also see what a little fragment in the middle there, and that's called a flex sign. So if you see an avulsion fracture, but not a true break across the second, third, or fourth metatarsals, you have to strongly suspect a Lisfranc injury. Because if there was enough force to do that, then there's probably enough force to disrupt that ligament. So what do we do if they're normal? Well, depends where you work, really. Most of us work in ERs or places where CAT scan is readily available. So if you're in a CAT scan readily available environment, you can order a CAT scan. If you're not, then you may have to try option one, and that is asking the patient to go back to x-ray, stand on their foot, and they take more x-rays. And typically the force of their own body weight will displace or aggravate that displacement or injury easier so that you can see it in an x-ray. Problem is they don't like it very much. They don't like coming in the first place, let alone asking them to stand up on their foot for more x-rays. So it's not really a humane thing to do, and not all of us are very good at ankle nerve blocks. Who's ever done one? I haven't. So I'm about to start doing it for the first time. But fortunately, CAT scans are more readily available, and you can see in this 3D reconstruction image the nature of the injury. Lateral X-ray shows the displacement dorsally. The oblique shows some displacement, but a widened joint there, and you can see the shifting off laterally. So what do we do in the emergency room? So you've done your due diligence. They come in, you see it, you recognize it, you've called it, you put the patient in a splint, you called orthopedists, and you're going to send them home. That's okay. The caveat is a well-padded splint right in this area. You want to allow cushion for the swelling. There's going to be a significant amount of swelling between now and when they go home or when they see their doctor. It's important to stress upon the patients, and then the first question they always ask me, whether they get a finger splint, a wrist splint, or a leg splint, is, when can I take a shower? Can I take it off, take a shower, and put it back on? And the answer is always, no, don't take it off. Leave it on. This is a non-weight-bearing injury. They should be non-weight-bearing, elevation, ice, until they see an orthopedic surgeon, at which time they will set them up for surgery to get it fixed. I don't know how they know this. Who was the guy that followed this squirrel around? Determine that. All right, so we've covered the wrist, or the distal radius, the foot. Now, a little more common thing, I've seen this a couple times in my career, perilunate injuries. So, case one, 22-year-old right-hand dominant male presents to the emergency department with a swollen, painful wrist after he fell off of his motorcycle on an outstretched hand at a high rate of speed. So, he comes to the ER, you see him, you do x-rays, they are read as normal. He was discharged with a wrist sprain. Next morning, he comes to the emergency room, same pain. Now, he has a new symptom, numbness to his right thumb, index, and middle finger. What nerve is that? What nerve is that? Median nerve, right? Carpal tunnel syndrome, we've heard of it. Maybe some of us have had it. I know I have. That is the carpal tunnel, the median nerve. So, radiographs were reviewed, and we'll come back to that. So, perilunate injuries. What's the spectrum of the injuries? Why are the dislocations easily missed? What are we looking for on x-rays? What's the main x-ray finding? An escapulunate dislocation, a little side note, but still related to the hand. What are the main x-rays finding of a lunate/perilunate injury or dislocation? 6, what are the consequences of missing one? And 7, how do we reduce them in the emergency department? Much, much easier than the distal radial ulnar joint injury. So question 1. What's the spectrum? Well, like any injury, it's a fall on an outstretched hand. One caveat is whether you fall with your hand dorsally flexed or palmar flexed, that's the same mechanism. So you get somewhat of the same injury whether you fall either way, but because we are inbred in our brain to do this, we see this as being the most common injury. So if anyone falls, that's when you have to suspect either a distal radial ulnar joint injury or a perilunate injury. So why are they easily missed? Simple. There's lots of bones in the hand, and they're often overlapped. The x-rays aren't perfect. They're not truly AP. They're not truly lateral. So there's lots of variations in what makes a good x-ray and a bad x-ray. And the patients don't always have a terribly abnormal physical findings. They kind of look normal. So if we don't suspect it or see it immediately, it's easy for us to miss it. And in fact, we miss it about 25% of the time. So what are we looking for on x-rays? So going back to your anatomy days, the Gilula or Gilula lines, okay, represent arcs of the carpals, okay? And in a normal person, healthy person, these lines should be smooth and follow the contour of each bone. So you have the capitate and the hamate, a nice arc there. The second zone would be through the scaphoid, lunate, and triquetrum bone. And then on the outer side of those bones is another arc. So if all of those lines are smooth, and you could so-called drive a car through them or around them, then you have no problem. If there's widening or overlapping in any of these bones, then you've got a problem. And it's time to look further. All right, so for the older folks in the room, you'll appreciate this one. For the younger folks, you'll appreciate the right image. So what is it? Scapholunate dislocation. That is a dislocation between these two bones, the commonly referred to navicular/scaphoid and the lunate. That space should not be there. They're almost touching all the time on any x-ray. So Famous guy, Terry Thomas, had a big gap in his tooth, so it became known as the Terry Thomas sign on X-ray. More commonly in today's day and age, we know it as Michael Strahan. Same problem. David Letterman and Madonna also have a similar thing, but I think David got his fixed before he retired. Okay, what are the main X-ray findings? We talked about widening of the scapula lunate. We talked about some of the problems with the distal radial ulnar joint. What do we find when we suspect somebody has either a lunate or a perilunate dislocation? Well, again, the money X-ray is the lateral X-ray. This can be very hard to discern. I challenge anyone here to look at that X-ray and tell me immediately what the patient's problem is, even if you knew the mechanism. It's very, very hard to see on an AP X-ray. You've got to look at the lateral X-ray, okay? And we try to draw, orthopedics is all about lines. They're big with lines. They should have been math majors. They draw imaginary lines through all the bones, and if there's no intersection or if there's a disruption of that intersect, then there's a problem. In the lunate dislocation, a true lunate dislocation, the lunate bone is pushed literally off of its insertion point, okay, and pushed outward. You can see it, like the Pac-Man sign. You can see it's there. On a perilunate dislocation, it's not really pushed off to the side, but it's sort of nudged and tilted on its edge because the the capitate is now sort of crowding its position along the distal radius. And again, it's best seen on the lateral X-ray. So here's the lines I was referring to. In a normal patient, you're going to see an imaginary straight line through the capitate in blue, through the lunate in red, through the distal radius in yellow. And that straight line, those all three bones should intersect almost in their middle, okay? In a perilunate dislocation, you're going to see, again, the lunate is still visible in that line, but now the capitate is now displaced, doesn't follow in that line anymore. So that means that this bone is the culprit. In a true lunate dislocation, you're going to see the capitate and radius line up beautifully on lateral X-ray, and now the lunate bone is tipped onto its side. For the older folks in the room, this is commonly referred to as the teacup on a saucer sort of mechanism. If you can imagine this being the teacup and that being the saucer, when it's tilted and you spill your tea, you have a true lunate dislocation. All right, so what do we care about? Well, we care about a lot of things. We care about outcomes primarily, but here's a couple clinical pearls. If we don't recognize it, if we don't recognize this in a timely fashion and they go home and then they come back and they go home and come back, and the longer time they go on without definitive treatment, they can end up with disability, long-term disability or permanent pain. And for those of you who've ever had carpal tunnel pain in the past, it's pretty dismal. So if you suspect someone, they come in, they fell, they complain of hand pain, wrist pain, and they not only have tenderness over the distal radius or anywhere in that region, but they also are complaining of numbness to their thumb, index finger, that median nerve distribution. You have to prove that it's not a dislocation of the perilunate or lunate until you can say otherwise. So it takes a very keen eye and might even take repeat X-rays. Don't be afraid to order more X-rays. If you don't like what you see, it isn't the right view, orthopedists would sure do it, so why can't we? Okay? Anytime there's unable to be successfully performed reduction, this constitutes an urgent call to orthopedics, and they may need to act more urgently than normal. In any case, whether you see a patient in the emergency room and you can successfully reduce them by the next slide I'm going to show you, or you can't, it still involves a phone call to an orthopedic surgeon. I can name no orthopedic surgeon who enjoys seeing a patient show up at their doorstep on Monday morning with a Lisfranc injury or this injury and no one called them ahead of time. They don't look kindly upon that. So how do we reduce them? It's actually pretty simple. It's one of the more simpler reductions that we do in the emergency department. It doesn't require anesthesia. Doesn't require anything special except the tools that we already had readily available to us, which is usually finger traps and a bed or a chair. You put them in traps, you get their elbow flexed at 90 degrees, so they're in somewhat of a comfortable position. You can see the thumb placement over the distal radius, okay, of the patient, and he's putting pressure on the backside, squeezing quite firmly with his right hand. He's then going to rotate without moving his left hand the capitate over and pushing the lunate back into place. When it happens, It's kind of frightening. It's a thud, snap kind of noise. You might think, oh my God, I just broke their wrist. But in reality, it's the bone snapping back into place because of the cup mechanism there. And they oftentimes go, wow, that feels so much better. Thank you. So once you do this, assuming it's successful, you get x-rays to confirm A, nothing is broken, nothing was missed on the other injuries, and you put them in a neutral splint. This is because the median nerve had been entrapped for some period of time if they have numbness of the thumb, index, or middle finger, and you want to make sure that you reduce any tension along that nerve. And keeping them neutral is the key. These folks oftentimes need surgery no matter what, but what you've done is buy them some time. They'll go see an orthopedic surgeon, a couple days, and then they'll go out and get it fixed. So going back to our case, patient goes to the emergency room, gets sent home with a wrist sprain, comes back to the emergency room with median nerve palsy or median nerve injury symptoms. You review the x-rays, and lo and behold, you see dislocation that was missed on x-ray. Patient then gets sent to the operating room for open reduction, internal fixation. As you can see, the joints have been restored. This was out of place. Now it's pinned and everything in line on x-ray as they drew the imaginary lines. So this is oftentimes what's needed anyway, but you want to avoid nerve damage, because once you get nerve damage, sometimes the effects are permanent. Questions so far? And I really don't know how they knew that. Lastly, pelvic apophyseal avulsion fractures. Again, the most infrequent thing. I've never seen one. I may never see one. Question is, what are they? What are the common sites affected by them? And why do we care? Why do we care about this? Well, A, we care because we don't want to miss it, first and foremost. But what are they? So the apophysis is part of the area of development where bones grow from. It's also serves as a muscle attachment. Most commonly in the pelvic region, this is the most common area, the ischial tuberosity. More than half of the injuries in this area are going to occur there because of the hamstring. Fortunately, it's not very common. 1–2% of people get it, and I've been doing this for 20-something years, and I've never seen one. Have I missed it? Maybe, but I don't think I have. So it happens because this area under development is very, very fragile. It is susceptible to injury. It is the weakest part of the bone, much like Salter fractures, Salter areas are the weakest part of a child's growing bone. So you can imagine, all these occur under the age of 25. How do we get it? Well, like any injuries, it's a sudden, forceful stop. Usually it's during running or jumping or kicking. So this happens usually in sports. We see it a lot in sports-age kids, football kids, soccer, etc. What are the common sites? Well, I mentioned earlier, this is the most common area in children. The other areas, of course, are all susceptible, and they do occur, but at a much lower rate. Okay, typically it's due before they fuse at age 25. So until that time happens, for most people, this is going to be an area of potential injury, but most of it occurs down in the pelvic region. So why do we care? Well, we care for a number of reasons. One, it's painful. Parents and children, they want to know how long they're going to be in pain. What does it mean to them long term? And like most sprains or fractures, most of them heal in 4 to 6 weeks, sometimes sooner if they're fixed in the operating room. But in these injuries, they're much longer. They're 6 to 8 weeks, maybe even longer than that. That may be a very generous estimation of how long it takes. So these kids are in pain for a long, long time. Okay. Commonly, management is non-operative, and the different types are 1 through 4. Kind of going back to the previous discussion, when is it operative, when is it not operative? Well, it isn't really for us to determine. It's up to us to determine the diagnosis, recognize it on x-ray, relay that information to an orthopedic surgeon, and then let them take it from there. But it can stem anywhere from just protected weight bearing, meaning you can do what you want to a certain degree, no sports or heavy activities, to total non-weight bearing. Okay. Lastly, the ORIF, when is it indicated? Well, again, this is an orthopedic issue, but as anything, there's always measurements that determine whether or not something is going to be really unstable versus something relatively stable. And they use degrees of separation. So greater than 3 centimeters or 2 to 3 centimeters displacement is often considered enough displacement. This is going to be an unstable injury and often requires it to be fixed. Fractures of the iliac wing and pelvic ring with or without instability, again, rely on degree of separation. Problem is malunion and non-union. So if we don't recognize it, they don't get the right treatment, they go on, and if life is normal, they're going to end up with a great deal of pain, either from scoliosis or a Trendelenburg gait. They're going to have a tilting of their pelvis. And our favorite emergency department complaint, chronic back pain when they're older, right? So to avoid all these things, try to recognize these things. I know it's going to be a little hard. It's not a real common thing, but something to keep in the back of your mind when somebody presents with pelvic pain and they're a child of growing age. Has anyone ever seen Bigfoot? I haven't. But if you find him, you better not kill him. Questions? All right.